We've walked the straight and narrow, but now it's time to jump into the wide complex tachycardias, some of the most feared ECG abnormalities. Open wide. Now, we usually go over the whole soap note for these sketches, but with VTAC, it's more like, oh snap! Not only because the VTAC is potentially lethal and the management can be challenging, but also because we're starting with objective, specifically interpreting that ECG. We'll look at what it means to be a wide complex tachycardia. Then we'll assess whether the rhythm is regular or irregular, including a look at the QRS morphology, which can be monomorphic or polymorphic. And to top it all off, the arrhythmia duration can be important, i.e., it can be sustained or non sustained. All right, ECG time. First up, are we wide complex or narrow complex? If it's narrow, you're in the wrong sketch, my friend. For an arrhythmia to be classified as a wide complex tachycardia, it needs two things. First of all, it needs to be a tachycardia, obviously. That means a heart rate greater than 100 beats per minute. Secondly, the QRS complex has to be 120 milliseconds or longer. That's equivalent to 3 small boxes on a standard ECG for scale. Just look at this police dog logo here with the QRS design in the back, along with a German Shepherd jumping right over those 3 boxes, each measuring 40 milliseconds. Why wide? Well, as we learned in our ECG how-to sketch, the QRS complex represents ventricular depolarization, and the duration of the QRS complex is the amount of time it takes for the ventricle to depolarize. If our electrical current is flowing from the atrium through the AV node and down the normal conduction system of the heart, this is the fastest way for the heart to depolarize and should take less than 120 milliseconds, creating a narrow complex. A wide QRS complex, on the other hand, develops when the beat takes a sneaky shortcut to get to the ventricles, outside of the normal conduction system. We'll see this in the setting of an SVT traveling in an antidromic fashion, which means that it hits the accessory pathway to activate the ventricles. Any SVT, in fact, that occurs above an accessory pathway can cause pre-excitation of the ventricles with each beat, creating a wide complex tachycardia. Here's an alternative scenario. Maybe the impulse is traveling down the normal conduction system of the ventricles, but the conduction system has some kind of abnormality. We'll see this in the setting of SVT with aberrancy. And thirdly, the beat can originate in the ventricle itself, again, outside of the normal conduction system. Think of ventricular tachycardia. Now, I know you're having fun reading the ECG and all, but in an unstable patient with wide complex tachycardia, you'll actually jump straight to management before more time is spent on making a definitive diagnosis. This unstable dude with the broken heart watch represents an unstable patient in cardiac arrest. Just to clarify, sudden cardiac arrest is the sudden cessation of cardiac activity with hemodynamic collapse, while sudden cardiac death means that the patient died from this event. While all wide complex tachycardias can lead to hemodynamic compromise, cardiac arrest, and sudden cardiac death, this is most likely in the setting of ventricular tachycardia and ventricular fibrillation, especially in patients with underlying cardiac disease. Hence the underlying damaged heart there. If your patient is in cardiac arrest or becomes unresponsive or pulseless at any point, it's time to run down the ACLS resuscitation protocol. That means CPR and immediate high-energy countershock. Unstable patients who otherwise have a pulse and remain awake and responsive will require emergency synchronized cardioversion. Hence the police officer running in with the paddles and synchronized heart watches. By unstable, I mean hemodynamically unstable. We are talking altered mental status, chest pain, hypotension, syncope, or signs of heart failure. As depicted by the intern here, who's suddenly wondering what was in that waiver he signed this morning. Stable patients with wide complex tachycardia typically present with palpitations and a sense of tachycardia. Depicted by our third intern here, clutching his chest and palpating with terror. Stable patients need to be on continuous cardiac monitoring with frequent checkups as they can decompensate rapidly. Now's your chance to perform a systematic inspection of the ECG. Alright, so the tachycardia is wide complex. Next, is the rhythm regular or irregular? As highlighted by the regular and irregular notes emanating from those dog whistles. Let's look at regular first, shall we? Ventricular tachycardia is by far the most common cause of wide complex tachycardia. And in this scene, it's represented by a ferocious VTAC dog with those jagged teeth resembling the wide monomorphic QRSs on the ECG. The term sustained monomorphic ventricular tachycardia means that the QRS complexes are fairly monotonous in appearance and, well, sustained. i.e., it lasts over 30 seconds. Just take a look at the QRS complexes incorporated into the fence. There can be slight variation, but the QRS complexes are otherwise wide and pretty stable. Sustained monomorphic VTAC is most commonly associated with coronary heart disease, especially in patients with a previous MI. Hence the clogged coronary crown worn by the chief here. Underlying structural heart disease, such as cardiomyopathy, is also a risk factor. So we've given the chief here a dilated heart bag full of doggy treats, evoking an image of dilated cardiomyopathy. Who's your good boy? Sustained monomorphic VTAC, along with VFib, are the major cause of sudden cardiac arrest and sudden cardiac death in these aforementioned patients. So, we've placed another number one foam finger, a ubiquitous dog training device, it turns out, pointing toward that unstable cardiac arrest dude from earlier. As a side note, non sustained VTAC, on the other hand, isn't quite as scary. Non sustained ventricular tachycardia lasts less than 30 seconds and is usually asymptomatic and only seen if a patient is on continuous monitoring. Which is why this guy monitoring with the binoculars is holding a 30-second timer. NSVT is often the bane of the night float intern, as it's often picked up on telemonitors overnight in asymptomatic patients. It's tempting to ignore these and go back to more pressing issues, or go back to sleep, but they can be harbingers of doom, aka sustained VTAC. Look for underlying things that might cause irritability of the ventricular myocardium, such as hypoxia, hypokalemia, hypomagnesemia, myocardial ischemia, or decompensated CHF, to name a few. Alright, moving on from VTAC. Our next wide complex tachycardia with a regular rhythm is SVT with aberrancy. Supraventricular tachycardia, remember, includes any tachycardia that results from pathologic impulse generation above the ventricles, such as AFib, A-flutter, and the reentrant circuits. Most commonly, these impulses hit the AV node and travel down the ventricular conduction system, creating a narrow complex tachycardia. What if, however, there's an aberrancy of sorts? To symbolize this, we've drawn in our usual SVT symbol, a surprise purse attack dog sending pathologic signals out from above the ventricles. This time, however, we've added a cute little bear keychain to the ventricle below. Think of it as an abnormality in the ventricular conduction system. An aberrancy bear, if you will. Let's say, for example, that this narrow complex SVT runs into something like, a bundle branch block in the conduction system. Just think of this bundle of sticks here taking the shape of a mannequin, blocking the path of this SVT attack dog. Ventricular depolarization is slowed with each beat, and boom, you've now got a regular and wide complex tachycardia, my friend. This can be related to a block on the patient's baseline ECG, or the block will only make itself known when the patient is in tachycardia, also known as a functional block. A functional block occurs when rapid-fire impulses hit conduction fibers that can't recover in time. Alternatively, instead of an abnormality in the conduction system, the patient could have an accessory pathway that leads to the ventricles outside of the AV node. This means with every beat, the ventricles are activated just a little bit earlier than they are normally. This is called pre-excitation, and it prolongs ventricular depolarization, leading to a widened QRS with every beat. We saw this over at the dog show with the Wolff-Parkinson-White pattern on the ECG. The presence of an accessory pathway caused pre-excitation with every beat, pulling out that QRS, which is seen as that sloping delta wave. Well, as you can imagine, any SVT that occurs above this accessory pathway can cause pre-excitation with every beat, and it will turn into a wide complex tachycardia, similar to SVT with aberrancy. So we've drawn in this overly excited Wolff-Parkinson-White wolf with an SVT chihuahua sending out impulses overhead. And finally, for our last wide complex tachycardia with regular rhythm, and the rarest of the bunch, I'd like to introduce you to the police force's newest line of anti-drone canines. This circular path on the track should remind you of the re-entrant circuit of AVRT. And you know the drill by now. These circuits most commonly run in an orthodromic direction. The impulse goes down the AV node, through the normal conduction system of the ventricles, and back up through an accessory pathway. Sneaky, sneaky. If the circuit runs backwards, however, in the antidromic direction, in other words, through the accessory pathway to the ventricles and back up through the AV node, now we're dealing with slower ventricular depolarization and a wide complex tachy. Just like the orthodromic version, antidromic AVRT is initiated by atrial or ventricular premature beats, but more rarely occurs. All right, now that we've witnessed the most common wide complex tachycardias with regular rhythm, I'd like to finish our discussion of rhythm by introducing a few conditions that cause irregular wide complex tachycardia. These will be next to all those irregular music notes at the top of the scene. When the rhythm is irregular, take a look at the QRS morphology. If the QRS complex morphology is variable, we call this polymorphic ventricular tachycardia. See how the fence is crunched in, creating wide varying amplitudes of QRS complexes? The classic example of a polymorphic VTAC is torsade de pointe, with an undulating morphology kind of like points twisting on each other. Hence the twisting strap on that bag of drugs being used to train the drug sniffing canine. The simple definition of torsade is a polymorphic VTAC in a patient with a history of prolonged QT. Hence the Q and T emphasized on her inspirational shirt. Prolonged QT can be congenital or acquired. Medications are a common cause of acquired. We'll remind you of this when we get into patient history. The big thing to keep in mind with torsade is, just like sustained monomorphic VTAC, it's associated with hemodynamic instability and sudden cardiac arrest and sudden cardiac death, though it commonly spontaneously terminates on its own. Now, polymorphic VTAC isn't only associated with long QT. Polymorphic, just like monomorphic VTAC, may be associated with an underlying cardiac condition, such as coronary artery disease with a history of MI, or some kind of structural heart disease like cardiomyopathy. Rarely, it's associated with a familial syndrome. All right, for our last wide complex tachycardia with an irregular rhythm, we need to talk about atrial fibrillation, classically described as irregularly irregular. It's symbolized, as always, by an irregular static trace across a screen. If AFib is affected by aberrant conduction through the ventricles, or if the AFib is sending its impulses to the ventricles through an accessory pathway, that whole pre-excitation thing, what results is an irregular wide complex tachycardia. So we've placed our AFib screen in the corner here, next to both of those previous symbols. All right, so far we have VTAC, SVT with aberrancy, and antidromic SVT causing regular wide complex tachycardia, while polymorphic VTAC and AFib with some kind of aberrancy or weird accessory pathway conduction are causing an irregular wide complex tachycardia. Remember, VTAC is by far the most common cause of wide complex tachycardia, especially in older patients or in patients with a history of cardiac disease like prior MI. With that in mind, let's look at some more clues on the ECG that can help us differentiate VTAC versus SVT. In general, the wider the QRS complex, the more likely it's VTAC. So we've drawn in one of the VTAC dogs leaping over 4 boxes, since studies have shown that over 160 milliseconds is an especially strong predictor of VTAC. Next, take a look at the axis. Extreme axis deviation is indicative of VTAC. We're talking in the minus 90 to plus or minus 180 degrees range. That's way over in the northwest direction. Just look at the direction of this signpost. There are a few other clues to look for as well, such as any large axis shift over 40 degrees from their baseline ECG. We've listed them in the video text. Next, take a look at that wall of fame. The word conquerors is meant to remind you of concordance, and they're numbered 1 through 6, just like the precordial leads on the ECG. VTAC is associated with concordance in the precordial leads, which means that the QRS complexes are all monophasic and of the same polarity, i.e., all pointing up or all pointing down, which is why the German Shepherd ears are all pointing in the same direction. If present, AV dissociation is another clue that you're dealing with VTAC. AV dissociation occurs when the atrial rate is independent of the ventricular rate, which can show up as dissociated P waves, fusion beats, and capture beats on the ECG. Dissociated P waves are symbolized by these interspersed P wave squirrels on this jagged QRS fence. When dissociated, the atrial P waves typically occur at a slower rate than the QRS complexes. The PP interval is different than the RR interval, in other words. Sometimes the P waves are buried within the QRS, but every few beats, boop, they pop out and make themselves known. Fusion beats occur when the ventricular impulse coincides with the supraventricular impulse coming from the SA node. This generates a QRS complex that's a width in between a normal sinus QRS and the wide ventricular QRS. A capture beat shows up as a normal QRS complex in the midst of all those wide complexes. For a brief moment, the regular conduction pathway is able to capture the ventricles, if you will, resulting in normal ventricular depolarization and a narrow QRS. All right, in the heat of the moment, we're now able to inspect the ECG and make a not necessarily definitive, but nonetheless educated diagnosis, differentiating between VTAC and SVT. Always remember, however, to check out a previous ECG if available. It might just give you that final clue you're looking for. We're going to be moving on to past medical history here, but I'll also briefly mention some corresponding findings from a previous ECG when applicable. First of all, take into account your patient's age. In general, older patients, typically older than 35, with wide complex tachycardia are more likely to have ventricular tachycardia, while younger patients are more likely to have SVT or AVRT. Why? Keep in mind that, in the vast majority of cases, VTAC is associated with underlying cardiac disease, especially coronary heart disease with previous MI. And, the older you are, the more likely you've got some kind of structural problem with the old ticker. With that in mind, get a past medical history, specifically assessing for any kind of cardiac history, especially prior myocardial infarction, congestive heart failure, or recent angina pectoris. Also, check a previous ECG for signs of a prior infarct. All signs point to ventricular tachycardia. How about an implantable cardioverter defibrillator? Does your patient have one of those, perchance? Well, that means someone at some point assessed them to be at increased risk for ventricular tachycardia or fibrillation, which clearly makes VTAC the most likely etiology of their current wide complex tachycardia. By the way, since we're on the subject of implantable things, I should mention that a wonky pacemaker could be the cause of your patient's VTAC. If the wide complex tachycardia is thought to be related to pacemaker function, the next step is to call cards, who will place a magnet over the pacemaker. Just like magic. Well, magnets are magic. Prove me wrong. Now, while it's clear that VTAC is typically associated with some kind of underlying cardiac disease, there are cases of VTAC occurring in patients with seemingly normal hearts. Seemingly normal, that is. One example is Brugada syndrome, which predisposes patients to VTAC and therefore sudden cardiac arrest and sudden cardiac death. Pretty brutal. Brugada syndrome is inherited in an autosomal dominant fashion, and it may have something to do with messed up cardiac sodium channels. The Brugada pattern on ECG includes a pseudo right bundle branch block, along with persistent ST segment elevation in leads V1 to V2, in case you needed another reason to check out that old ECG. Regarding SVT with aberrancy, check a prior ECG for a history of some kind of aberrancy. We're talking fascicular and or bundle branch block. Look for those classic rabbit ears. And, of course, assess for a history of SVT, including atrial tachycardia, AFib, aflutter, AVRT, all that good stuff. Look at their baseline ECG for any clues. Two things to keep in mind here. Number one, an SVT running into an aberrancy is much more common than antidromic AVRT. And number two, AFib with aberrancy will produce an irregular wide complex tachycardia more often than not. Bonus points for recognizing Wolff-Parkinson-White pattern on a baseline ECG, which indicates the presence of an accessory pathway with pre-excitation. For more specifics on AFib, aflutter, and AVRT, head on over to our narrow complex tachycardia sketch. Anyways, if there is any history of a supraventricular tachycardia, try to figure out if they've had wide complex tachycardia before. And finally, don't forget about torsade. Assess for a history of long QT syndrome. Checking a prior ECG can't hurt. Get a detailed medication history as well. Many medications, including antiarrhythmic drugs and some antimicrobials, prolong that QT interval. As for objective data, because we've already covered the ECG, we'll go straight to labs. Check electrolytes, as both hypokalemia and hypomagnesemia can cause VTAC. Check those cardiac troponins as well, especially in patients presenting with chest pain and hemodynamic instability. That very well may be a heart attack, my friend, precipitating VTAC or VFib and ultimately sudden cardiac arrest. Remember, though, troponin 1 and CKMB can take up to 6 hours after the chest pain presents to be detectable. All right, who's up for a sample assessment? Wanda is a 65-year-old female with a history of hypertension, CAD, and MI 5 years ago, presenting with a 1-hour history of left-sided chest pain, dyspnea, and confusion. She's currently taking spironolactone, metformin, and metoprolol. On physical exam, her blood pressure is found to be 85/55 and her pulse is 176. She appears to be lethargic and is oriented only to person. Crackles are heard bilaterally in the chest. The ECG demonstrates QRS complexes consistently widened at 164 milliseconds in duration. ECG also exhibits extreme axis deviation, concordance of the precordial leads, AV dissociation, and capture beats. Electrolytes and cardiac enzymes have been ordered. Given her medical history and ECG results, she's most likely experiencing ventricular tachycardia secondary to underlying structural heart disease or current ischemia. She is unstable and requires immediate synchronized cardioversion. As mentioned prior, the most important part in determining the treatment plan for a patient with wide complex tachycardia is an assessment of their stability. Patient in cardiac arrest? Start the ACLS protocol with CPR and immediate high energy countershock. Unstable patients with a wide complex tachycardia require immediate synchronized cardioversion. If they're stable and known to have SVT, we can attempt vagal maneuvers, such as Valsalva maneuver or carotid massage. Just think of this attack chihuahua here getting a full-on carotid massage as he's grabbed by the neck. AVRT is dependent on transmission through the AV node. A transient AV block caused by these maneuvers, therefore, should terminate the arrhythmia. Next, try adenosine, which works the same way. Gotta block that AV node. If it terminates, a re-entrant tachycardia, such as AVRT, is the most likely diagnosis. Adenosine can also slow the rate enough to expose the flutter waves or fibrillation characteristic of A-flutter and A-fib, respectively. Proceed down their respective management pathways if applicable. We'll get way into the management of A-fib and A-flutter a couple sketches from now. Suffice it to say, we're looking at rate control versus rhythm control. Let the slow dancing commence. Refractory wide complex tachyarrhythmia requires synchronized cardioversion. What about patients that are stable yet have apparent persistent changes in their ECG suggestive of ventricular tachycardia? Current ACLS guidelines state that IV amiodarone is first-line therapy. Man's best amigo. As highlighted by this pro-canine, IV procainamide may also be given if the patient is not significantly hypotensive. Refractory patients, yet again, go to synchronized cardioversion, though some clinicians will jump straight to this step in the setting of suspected VTAC. What about cases of apparent torsade de pointe? The treatment of choice is IV magnesium sulfate. At Sketchy, magnesium is symbolized by a magazine. Police Dog Monthly. That's a good read. How about long-term therapy? The SVTs are discussed in other sketches. Long-term therapy for prevention of VTAC includes placement of an implantable cardioverter defibrillator in patients at high risk of sudden cardiac death. Usually, this is in patients in whom a reversible cause of their VTAC cannot be identified, or those with underlying cardiac disease. That includes patients with Brugada syndrome. In summary, when the diagnosis of VTAC versus SVT with aberrancy is uncertain, treat for VTAC. Adding a nodal blocker, the first-line treatment of SVT, to some patients with VTAC can precipitate hemodynamic collapse. Treat the VTAC first. That's right. What seems like a harmless little SVT chihuahua could be something much worse. Aw, so cute. Who's my little supraventricular? Oh shit!